Hello there, and welcome to this program entitled Preventing RSV, providing older patients with the information they need. My name is Chuck Vega, and I'm a clinical professor of family medicine here at the University of California, Irvine. And I'm delighted to be joined by Sarah McLean and Pam Rockwell, and together we're going to just be a powerful team imparting some important information regarding RSV infection and how to prevent it. So I'll let them introduce themselves. Pam, do you want to go first?
Sure. Thank you. Glad to be here. I'm Pam Rockwell. I'm a professor of medicine at the University of Michigan Medical School, where I've been teaching residents, medical students, and seeing patients for over 30 years. And I also am just stepping down as the ACIP, Advisory Committee on Immunization Practices, liaison for the American Academy of Family Physicians after 7 years, opening the door for somebody new to start. And at the state level at Michigan, in the state of Michigan, I chair our Department of Health and Human Services Immunization Committee. Glad to be here.
Thank you for your service, by the way. So well-deserved break. Sarah, do you want to go next?
I'm Sarah McQueen. I'm a physician assistant. I have been in family medicine for 16 years now at FQHC in the southeastern United States. I am also the AAPA liaison to the ACIP Combined Immunization Schedule Work Group, and I love to talk about vaccines, and so I'm excited to talk with both of you today.
So the two of you are very well versed in RSV and how important it is as an infectious process, but that's not always the case with the patients we see are generally in the community. So maybe we could talk and start talking about, there's a knowledge gap in the community, particularly among older adults regarding RSV. Could one of you address that a little bit?
There is a huge just disparity in adults that are aware that they too can get RSV. And I see it all the time. I see it in the nursing home. I had a patient recently that I followed up after they had gone to the hospital with a fairly severe RSV case. And I didn't even know I could get RSV. I thought that was just for babies. And there's even been some surveys of the general public. And there are these just huge gaps. Around only 43% in this one survey knew that RSV could affect adults. And so I think there's just a big gap in our education and a great opportunity for us.
And I'd say that it's not just our patients in our community, but providers themselves, healthcare professionals, don't often think about RSV very much when it comes to infections among older adults. I was trained and RSV was something that affected kids and hospitalized kids during winter only. And especially the last couple of years with an epidemiology that's changed a lot thanks to the COVID-19 pandemic, we're seeing a lot of different folks of all different ages. And I think there's greater emphasis now on how important RSV is as an illness. And many patients actually enter the hospital with RSV as adults and don't know they have it.
Absolutely. And I think we look at our adults who we would diagnose with COPD exacerbation, asthma exacerbation, respiratory failure, all of these issues, and we wouldn't know why. We would assume viral. We would assume maybe just disease progression, weather change, those types of things. And so now we're getting a name to it. And I think it is very surprising, but I also think it's very satisfying. I think once you have a name and there's a reason for it, it isn't so mystifying. I think it would be great if we had treatments, good treatment options, but I do think it's good that we're able to have a name on these illnesses.
Exactly. I think patients are aware of RSV because they've had children and their children had RSV. But what they didn't know is that it could affect them as adults. And I think physicians were, at least in my environment, were unaware at the impact it had. And so my goal with teaching residents and medical students and my patients is to be aware that RSV could be the cause of their symptoms. And it's not necessarily going to be flu or COVID as people are expecting.
But I think the fact is that that we do need to take RSV seriously. It is a major source of morbidity, time off work, time off school, recognized. But in terms of who has the most serious sequelae, in terms of severe morbidity, hospitalizations, ICU stays, and mortality, it's really that the older population is affected, perhaps even more so than other viral infections such as influenza. There's some research showing that that compared with influenza, the folks, older adults who are admitted to the hospital with RSV have longer hospital stays, higher rates of ICU admission, and a higher rate of mortality within 1 year of admission. So it's not something to be trifled with. This is not just a bad cold, and therefore, I very much agree with you, Sarah. Like, I think it would get more attention if we had more therapeutics in the area, but now we do have means of prevention, at least, which is, if you can prevent something, it's almost always better than treating it, right? And so we have to get that word out there. What do you think about, and what's been your experience in terms of the severity of RSV infection, particularly as it applies to older adults, maybe with comorbidities?
So for me in general, it's still been slow for testing in our hospitals. We're in a rural setting, and so I think it's still common to get acute URI, pneumonia, NOS, those kinds of diagnoses back from hospital stays. But just a personal vignette of mine is the patient that was at the nursing home and got sent out, but they were able to come back with oxygen and some nebulizers, and they just said, I haven't been this sick in my whole life. When I had COVID, I didn't even know I was sick, but I was super sick with this. It was terrible. I didn't get to do my workout. I didn't get to go to the cafeteria. I had to stay in my room, and so then there was this whole level of isolation too. But there was definitely, they were very short of breath and just a struggle just because of their comorbidities. But we are still a little bit slower around here to get the diagnosis.
For me, the data that really struck me was the mortality rate being higher for RSV associated hospitalizations than influenza. Now, of course, this subset of patients who are in this category likely already have some lung disease or chronic disease that makes them more at risk. But I feel like there's been such a public health information outcry about influenza and get your flu shot every year. And so now we just have to start the information going out about RSV vaccines, because it can really make a difference, not just for patient health, community health, and it'll be medical costs to our healthcare systems, length of stay. And plus, I'm a big fan of testing for RSV, COVID, and influenza if you have that ability when patients are admitted, if not a full respiratory panel, which is quite expensive. But we do have some antiviral treatments for other diseases. So by diagnosing RSV and eliminating other diagnoses, you also save money on inappropriate antibiotics use and inappropriate antiviral use of other types.
So this was a great start, I think, to our discussion, and it's a nice framework to begin with. And now we are going to move on in our next section to some of the other burdens in terms of both patient burden and individual burden, but also the financial burden, the significant financial burden associated with RSV disease, particularly among older adults.